CTV, your official source for government information.
Your husband had a massive heart attack. We all know what those words mean. Heart disease is America's #1 killer. Heart attacks result when the blood supply to the heart muscle is severely reduced or stopped. Because many victims don't recognize the warning signs, only 1 in 5 is able to reach a hospital quickly enough to benefit fully from treatment. But there's good news. First, you can help yourself. Good eating habits, physical activity, preventive screenings, and avoiding drugs and tobacco can significantly reduce the onset of heart disease. Second, major advances have improved the fight against heart disease. More is known about its causes, there are new diagnostic tools to detect and counter it, and improved treatments are available that help people recover from it. What is heart disease? Are you at risk? What can you do about it? And what are some of the exciting innovations in this important field? Hi, I'm Rich Krieg, host of On the Horizon, and with me in the studio today are Dr. Jerome Hantman, Chief of Cardiology, Howard County General Hospital, Dr. Stephen Geller, Internal Medicine, and Susan Sims, Cardiopulmonary Rehab Nurse. Welcome to On the Horizon. Dr. Hantman, let me ask you a simple but very complex question. What is heart disease?
Well, heart disease is a big topic. There's a lot of different kinds of heart disease. Obviously, there's congenital heart disease that you can be born with, valvular heart disease that you might catch like with rheumatic fever and develop it later in life. And there's electrical heart disease where you might need a pacemaker, but the vast majority of individuals in this community who develop heart disease will develop it on the basis of coronary artery disease, cardiovascular disease, hardening of the arteries, heart attacks, angina, and eventually some weakness of the heart muscle. So the vast majority of people that come into the doctor's office with heart disease have coronary artery disease.
Now, Steve, give us an idea of the prevalence in a community like Howard County, or in the country for that matter, of heart disease.
Well, heart disease is a very common disease among patients. It's probably the greatest killer of all people, in greatest cause of mortality among both men and women, both whites and blacks. So it affects everybody. And in terms of our office practice, we see it very commonly. This is a very common problem that affects everybody as they get older generally.
Are there any myths? Let me ask the two physicians on the panel. Are there any myths about heart disease in terms of things that you hear that just aren't true about heart disease? Let me ask you.
Well, one of the myths that is very important in a community of young, dynamic individuals is that heart disease is a disease only of older people and only of men. Women do develop heart disease later in life by 7 or 8 years, but when they get the heart disease, coronary artery disease, they seem not to do as well with it. They have a higher mortality rate when they have a heart attack. They don't recover as well after they've had coronary bypass surgery, and they don't have as good an outlook or an outcome when they have angioplasty or catheter procedures. So women do develop heart disease later in life, but when they get it, they have more trouble with it. And women are much more likely to die from heart disease than they are from breast cancer, which is one of their greatest fears.
I think that is a myth. Let's stick with the subject of risk factors. Steve, why don't you talk a little bit about what you see as the risk factors for heart disease?
Well, there are many risk factors for heart disease. Among them are certainly high cholesterol. That's a classic one. Other risk factors are family history. If your parents had heart disease, you're more likely to have it. Other risk factors are male sex or females after menopause generally. As Dr. Hantman said, it occurs later in females, but still it happens in females after menopause. Other risk factors could be lack of exercise, being overweight, bad diet. All those are risk factors as well.
Now, I didn't hear you mention stress as a factor. Is stress a factor for onset of heart disease?
I think it probably is. I mean, I don't think there are very good studies that can document that stress is a risk factor of heart disease, but I think you have to think that it is, because it puts a stress on the body, and therefore, when the body is stressed, you're at increased risk for heart disease.
And so when we talk about this, it's a fairly complex disease. If you took the simple notion, let's talk about coronary artery disease. You're talking about, if you think of the heart as a pump, and you've got the arteries providing blood to the heart, you're talking about a thickening of the blood vessels. Could you talk a little bit, perhaps, about the physiology of that? What happens when you have the thickening that we talk about in heart disease? What's the process involved there?
Well, if you start off with a normal artery, it has a very smooth wall. The artery expands, the artery contracts, it's smooth, things don't stick to it. As you get older, cholesterol may stick to it, calcium may stick to it, and you get deposits called plaques. And they build on each other, just like the snow that we've had recently, piles on each other. You don't want to have that started, but we learned many decades ago that American males, soldiers, had a lot of the plaque already in their early 20s. High blood pressure and diabetes also are very much related to the development of the plaque. Cigarette smoking, it shouldn't go without saying, goes with saying, cigarette smoking is bad for you, increases the rapidity with which the plaque develops. As the plaque develops, the arteries get a little bit narrowed. A heart attack doesn't usually occur when the narrowing becomes 100%. It occurs when one of these plaques rupture. And if those plaques rupture, suddenly there's an expansion, there's a blood clot, it blocks the artery, and that's when you have a heart attack. So in modern cardiology nowadays, which is just a few years old, our goal is to keep those plaques from rupturing, even more so than keep those plaques from developing. So a lot of medications and studies are done to find out who is at risk for having one of these plaques rupture.
Now, Susan, I've heard the term an ounce of cardiac prevention is worth a pound of rehab. What does that mean to you?
Well, cardiac rehab, I think, is very important. We see these patients after heart attack or after bypass surgery or angioplasty. So it's really, we're not doing primary prevention, we're doing more secondary. So, but we do, though we work on getting their confidence back and increasing their exercise capacity, making them feel better, we are working on identifying and reducing their cardiac risk factors, like both the physicians mentioned, working on hypertension, elevated cholesterol, obesity, stress, cigarette smoking, poor diet. So we identify the risk factors and then we help them modify their risk factors to prevent a second event.
Now, someone might say, well, I don't smoke, I have a fairly balanced diet, I get some exercise, not as much as I should, but I get some. Should a person like that be concerned, or should they routinely do some things just to ensure that they don't have a problem? Dr. Hammond?
Yeah, one of the things that we do, I think, fairly well in Howard County, because it's a young, dynamic population, is that we do a fair amount of risk factor analyses and testing on individuals who are free of symptoms before they get into trouble. If you take the female population, 60% of the women who end up with a heart attack have had no symptoms prior to it. And that's a problem. I mean, they could be 40, 50, 60, or 70 if they had no symptoms. We feel in primary care and cardiology that we can pick up a lot of these people that are at risk.
How many of those people have death be the first presenting symptom?
Well, statistically across the country, they say almost 50% of the people that have a heart attack, it's the first symptom and they die from it.
So a lot of people are walking around right now in Howard County who have some undisclosed problem that they have. And would you agree? What sorts of things should let's say, relatively healthy feeling people do on a routine basis to ensure that they're doing the right things?
Well, sort of as you said, for one thing, they want to do some moderate amount of exercise. They want to try and follow a prudent diet. Those are the types of basic things they can do. They probably should see their physician to try and check for the modifiable risk factors, things like cholesterol, which can be fairly easily treated. There are some new risk factors, which we can talk about later if you'd like. And there are some other things like monitoring for diabetes, monitoring for high blood pressure, which is usually asymptomatic until it's checked by a physician or found by a physician or a nurse. So going to the doctor to get checked out is probably worthwhile because they can pick up these risk factors that we can modify and prevent them from getting heart disease in the future.
Yeah, you hear about stories. I remember Darryl Kyle, who was a pitcher with the St. Louis Cardinals, I think last year, 33 years old, professional athlete, died. I recall last December. There were two physicians and some others who were jogging, who apparently were in very good shape, probably in their 40s, who died and apparently didn't know they had a problem. I'm assuming that's not commonplace, but what happens there that people who are taking exceptional care of themselves all of a sudden die from a heart attack?
Well, for one thing, they can develop an arrhythmia, which can cause sudden death, which may occur either because they had undiagnosed heart disease in the past. That's one possible outcome or a reason for why they could have sudden death. They also may have had a plaque that is only partially obstructing the artery that suddenly ruptures and causes a total occlusion, and that's what causes a heart attack. And they may be totally asymptomatic before they have the terminal event.
Okay, so Jerry, could you fill us in on the kinds of diagnostic procedures that you do at Howard County General Hospital? Someone comes in, they're concerned, or come in for a routine procedure, and you get concerned. What are the range of things that you have to diagnose the situation?
Well, Howard County is, there's over 20 cardiologists on the staff of Howard County, so there's no shortage of specialists to do certain tests. Usually by the time the patients come to us, they've been seen by an internist, they've had their blood test, their cholesterol, their diabetes, their blood pressure checked. Now we're testing C-reactive proteins, which gives us a pretty good idea if they're at high risk, even if their cholesterol is normal, and a homocysteine level, which is another blood test which gives us an idea. Not available directly in Howard County, but is available through Baltimore area is an electron beam CAT scan, where you get a CAT scan, it takes less than a minute, and you can find out how much calcium is deposited in your coronary arteries quite accurately. And there's good reason to believe the more calcium that you have, the more plaque that you have, and the more plaque that you have, the more trouble you might be. As a cardiologist, I spend a lot of time doing stress tests. We do regular stress tests, we do nuclear stress tests, we do echo stress tests. A lot of those joggers that don't do well, who feel well, might not pass a stress test. They would get on the treadmill, they would try to do their exercise. They might feel well, but their electrocardiogram might become very abnormal, and their radioactive pictures might become very abnormal, suggesting they have significant coronary disease. Some athletes, we have some examples from the past from the University of Maryland basketball players. They had died suddenly, and the echocardiogram showed they had some muscle abnormalities of their heart, congenital, that develops at age 15, 20, 25. An echocardiogram would pick that up, so a lot of individuals nowadays get an echocardiogram as part of their complete cardiac evaluation. We find some interesting things. One of the frightening things is that we all get the flu. We get a virus infection. We have aches and pains for 2 or 3 days. We get better. We assume we are better. A very small number of those individuals go on to have something called myocarditis, or an inflammation of the heart muscle, but they feel fine. Their heart muscle is weak. If they go out and jog vigorously, they may die suddenly. Very rare, but when we see young individuals and young athletes, aside from this one that recently might have taken an excess of ephedrine, which is a particularly dangerous drug, as a stimulant to help diet and increase energy, there are times when you need to listen to your body. Wait a while before you go back to heavy exercise if you've been recently quite sick. In the hospital, we have a heart catheterization laboratory where we can do diagnostic catheterizations to find out if coronary arteries are narrow. We have the full complement of stress testing, echo, and all that in the hospital. What we can't do at Howard County yet is treat an abnormality of the coronary arteries once we find it. Community hospitals are not permitted to do that in Maryland and in most states without surgical backup. Now, that may be about to change. The state is about to reconsider that. But for a community hospital, we have a pretty good complement of all the cardiac tests that need to be done.
You're one of the Hopkins, part of the Hopkins system. I think they have about a 25-bed coronary care unit there. They do transplants there. Is there a fairly active relationship between the physicians here in Howard County and the Hopkins people, Steve?
Yeah, I think there is a good relationship. Usually what we end up doing is transferring patients who need more extensive cardiac care than can be provided at Howard County. Predominantly those who need angioplasty or who need cardiac surgery get transferred from Howard County General down to Hopkins, where they, as you said, they have large number of ICU beds, but also more importantly have the ability to do the cardiac surgery and do the angioplasty, which we can't do at Howard County General yet.
Now, the basic process, just in lay terms, is if the heart gets deprived of oxygen, if there is a blockage or restriction in the artery, scar tissue gets formed, and basically that part of the heart's lost forever, is it not? And your job is to look at the rest of the heart and try to get that into optimal or most efficient functioning. What happens once the person comes to your unit? What phases are gone through?
Okay.
How do you work with people there?
Well, there's actually 3 phases of cardiac rehab. Phase 1, which I am involved in, is inpatient cardiac education. And that would be ordered perhaps by one of these physicians, where they ask me to go and see their patients to explain either a cardiac diagnostic test, maybe cardiac catheterization, coronary angioplasty, maybe to discuss with them how to live with congestive heart failure, the different medications and diets that they should be adhering to after discharge. So that's one possibility, is that I would see the inpatient population. That's called phase 1. Phase 2, which is...
and part of that is to motivate them to go along with the regimen or...
Correct. Hospital stay is so brief now with cardiac disease. I mean, usually they're in and out of the hospital, or they're transferred so quickly that the opportunity to educate them during that brief hospital stay is difficult. So by far, more of the education is done during phase 2 cardiac rehab. But my initial goal is to prepare them for what the doctor has ordered, or to give them the initial understanding of what their disease process is, so that they can take that information. Of course, I provide them with videos and written material, pamphlets, booklets, etc., as well as a contact number that they can follow up with us. Now, phase 2 is something, cardiac rehab, that's an outpatient. The patient comes into our facility. They are again referred by one of their physicians. They are either status post heart attack patients, or they're recovering from bypass surgery or angioplasty. Those are the 3 types of patients that we see. They spend anywhere from 4 to 12 weeks in our program. It's 3 days a week. It's Monday, Wednesday, Friday, and they spend an hour with us. And the goal of that program is exercise and education. And again, it's secondary prevention. It's more of a thrust. Well, yes, you've had this cardiac event, be it a heart attack or you've had an angioplasty. What can we do from here? We, of course, help them recover from the event, but we want to look at their risk factors and help them incorporate lifestyle changes to reduce their risk factors. With, of course, the very important cooperation between the cardiologist, the primary care physician, the cardiac nurse, exercise physiologist. We have a dietitian that works with us. We have a cardiac nurse educator. We also have a diabetic nurse educator. So there's it's a team approach, and the thrust is to get the patient to modify the risk factors that they can modify.
And is it entirely a physical process, or are there some psychological aspects of what you have
it's
to work with?
very much both, physical and psychological. There's an intake interview that I do most of when the patient comes in, and there is some forms and surveys that they complete prior to meeting us, and those are mostly psychological surveys, asking them how they're feeling about their health, how well are they doing, how do they see their future, do they feel they're going to recover, those types of questions. And then when they come in, we do a brief history and physical. We write an exercise prescription for the patient that, of course, our medical director must sign off on. He is a cardiologist. And then the patient's stratified into a low, medium, or high risk category. And from there, we work with those patients for the next 4 to 12 weeks, depending on how much coverage or how many sessions they're entitled to.
I assume when they come back and you put them on an exercise routine that do you have them hooked up to a heart monitor?
Yes, we do. Actually, they wear a telemetry unit, which is a little portable heart monitor, and there's 8 patients per class, and they rotate through similar to what you would see as a gymnasium. They go on 2 aerobic pieces like treadmill and bicycle. Then they do upper body training, which is free weights and arm ergometer. But throughout, the blood pressure, heart rate, and rhythm, as well as any changes in their ST segments, are monitored and, of course, reported back to their physician.
Okay, and I imagine it's difficult for some people to get off that monitor because they're afraid that something will happen with more exercise.
Well, the main thing, I think, that most of our patients come in, they're very frightened. That's, they've had a heart attack pretty much unexpectedly. They may have had heart surgery. A lot of these patients were asymptomatic, and here they find themselves. And so our goal is really to build their confidence, to make them feel better. And sometimes we have to push them along after that 12 weeks and get them into the next phase of rehab. And they're often reluctant to leave because they've developed a good rapport with us. We've made them feel better. They know they're safe. They're going to be okay. So we then, after they finish with us for 12 weeks, we like to refer them to phase 3, in the final phase of cardiac rehab, which is affiliated with the hospital. It's called Central Maryland Rehabilitation. They're off-site. They're not on the hospital campus, but they're in Columbia. And they do a nice 12-week program After our patients have graduated phase 2, they no longer need a telemetry monitor, but they still want to be in a medically supervised program. An exercise physiologist runs that program. She monitors blood pressure and heart rate, and she instructs them on what they should and shouldn't be doing, when they should increase their exercise. So that's the final step before they go back into their own gym or exercising on their own. And hopefully their education process will be complete and they'll know the signs and symptoms, what to look for, and so forth.
Okay. Jerry, people out there, they hear terms like angioplasty and stents and all kinds of terminology. Could you run down, for those who haven't thought about it, and I think there are many people who really have not thought about this, what are the range of treatments that are available? Maybe we could start with the drug treatments that are the standard ones that might be used by a physician, depending on the characteristics of the case.
Well, if we're dealing with coronary artery disease, our primary concern and hope is that an individual won't become symptomatic and won't have any damage done. So we want to minimize the narrowing of the coronary artery, and we want to minimize the blood pressure, we want to minimize cholesterol levels and whatever. And there are some really good medicines for diabetes out there. Certainly there's lots of medicines related to blood pressure. The cholesterol is the one that we're hitting on most strongly now. There's a group of medicines called the statins, which has Mevacor and Lescol and Lipitor, Zocor, Pravachol. You see them advertised on television by some of the coaches of the teams, and it's a hot ticket item. Many of us cardiologists would like to see that in the water with the fluoride. It is a good category, very safe. If you have side effects from it, they're infrequent. You stop the medication, the side effects go away, if you understand what the side effects might be. Lowers the cholesterol, lowers your C-reactive protein, reduces your risk of having heart attack and strokes. It's great to help prevent heart attacks. It's great to try and prevent follow-up, repeat heart attacks. So the statins and niacin are really being used quite a bit to try and lower cholesterols and prevent heart attacks. Once you have coronary artery disease and you've failed a stress test, then you need a heart catheterization, which a long, thin plastic tube is inserted into the groin artery and advanced to the heart, and you can actually take pictures of what the coronary arteries look like if they're 50% narrowed, 90% narrowed, if one artery is diseased, 3 arteries are diseased. Some individuals don't need anything done about it except for the risk factor modification we're talking about, but some individuals have 60, 70, 80, 95% narrowing. They need to have that fixed somehow, and most of the time now we take a catheter that has a balloon on the end. The catheter goes in where the narrowing is. You blow up the balloon from outside. It stretches open, pushes the sides of the plaque up against the wall as if it were a marshmallow. And then in order to keep it from coming back into the channel, you put a slinky type of a thing, a metal or a device which goes in there and holds the artery open. That's a stent. And stent is big business now. A lot of people are getting stents, and there are some new stents coming out within the next few months that are coated stents that seem to keep the artery open better than all the previous stents that have been made.
And Susan, you said that people these days are in and out pretty quick, which I think the public might be surprised about.
Right.
But for angioplasty, for example, is the person under general anesthesia?
Now, angioplasty, there's what's known as conscious sedation, twilight sedation. You have to sort of participate, because if they want to take some pictures, you have to hold your breath. So you say, hold your breath, so they have to be awake enough to hold their breath, otherwise you have a moving field. When you're talking about how long we're in the hospital, when I started in medicine in the 60s, 6 weeks after a heart attack, we used to have to sedate people to keep them in the hospital. Then it was 3 weeks, 2 weeks, 1 week, and now it's 3 to 5 days. It's amazing.
Jerry, Steve, is talking about the acceleration of change and the marvelous innovations that are occurring in cardiology. One of the upcoming sea changes is genetic medicine. And I guess the simple-minded picture I have in my own head is that this being a complex disease, that eventually there'll be markers, and some are available now. I think I read somewhere there are 250 different genes that may interact in terms of arterial disease. But what do you see coming down the pike on that? Are we going to, what changes would you see in diagnosis, treatment, making better use of existing treatments?
Right. The whole, that's a really interesting field that's going to be developing over the next few years. My hope is that by drawing a sample of a blood test from a patient, you'll be able to pick up whether increased risk of certain diseases, including coronary artery disease, and can target the people who are at most risk for the more aggressive interventions we've been talking about, like the like statin treatment and like treatment monitoring their diabetes and for hypertension, as well as that the calcium score by electron beam CAT scan. You'll know who to look for more closely and who not to look, who doesn't need quite as intensive of an observation. So that's the diagnosis piece. I think that's really going to be interesting. You may even know that for me, you need to look for diabetes, and for somebody else, you look more for hypertension. For somebody else, you look more for heart disease as what you're looking for, or cancer, or whatever. In terms of treatment, it'll be there's even some interesting idea that by injecting vascular growth factors into somebody's heart or through a catheter or something like that, you can cause new blood vessels to form that would sort of develop their own bypass, so they wouldn't even need to.
And the heart does that a little bit itself, doesn't it?
Yes.
Exactly.
On a collateral basis. There.
Exactly. So the hope is to increase the amount of collaterals that develop, and so you may not need to do surgery to do bypass. You can do bypass by getting the heart to develop its own collaterals, and that would be really great if or when we can do that. It's not quite there yet, but in the future.
We only have a few minutes left, and I thought maybe, Susan, I'd give you the last word. You must see it all. Everybody at this table sees life or death issues on a daily basis with heart disease, but you must see a lot of cases where people say, my gosh, my heart's been damaged. It was so simple to prevent this. Not trying to minimize giving up smoking and so on.
Right.
But what do you say to people out there in the audience who may have one or two of these risk factors, but really are pretty lackadaisical about coming in and asking for some help or some guidance? What would you say to people
Well, I
like
would
that?
say, as a physician said, I think it's very important to see your physician if you're at a certain age, let's say on a yearly basis, and have your risk factors assessed. Are you hypertensive? You may not know that. You may not know if your pressure's high or not. Get your cholesterol checked. Incorporate exercise into your lifestyle. At least 3 days a week is the recommendation. That's the minimum for 30 minutes. Low fat, low cholesterol diet. Quit smoking. Have your blood sugar checked. There's a lot of risk factors that can be modified, and for those that you can't, well, you can't change family history or genetics, but you certainly can work on those modifiable risk factors. So I would say follow up with your physician. There's also, the phase 3 program is not just for patients that have had heart disease, which I failed to mention earlier, but for those people that have risk factors for heart disease, a phase 3 program might be a nice way to go. Getting involved in that 3 days a week. And they will look at your risk factors with you and help you modify them.
So if a person was interested in that, where would they call? What part
Well,
of the
it's called
hospital?
Central Maryland Rehabilitation, and it's on it's on Woodside Court, which is in Columbia. And they can get that number through the main hospital, and they can ask for the phase 3 cardiac rehab program. And they do not need a physician's order for that. They do not need to have had a cardiac event. That's what you call primary prevention. It's getting in there and exercising and having your risk factors looked at before the event.
Well, I hope our audience takes this very wise advice today. And I'd like to thank Dr. Jerome Hampman, Steve Geller, Dr. Steve Geller, and Susan Sims for being here today. And thank the audience for watching On the Horizon. We'll see you next time.
GTV, your official source for government information.